Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Courtney Smith. Today's episode features expert insight from Dr. Robert Gish on the burden and impact of HBV infection, as well as strategies to overcome barriers to vaccination. This episode is part of a larger educational program titled Adult Hepatitis B Vaccination, Keys to HBV Prevention and Control. For more information about Dr. Gish and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Gish has to say on this important topic.
Greetings. My name is Dr. Robert Gish. We're going to talk today about hepatitis B vaccination in this Clinical Care Options Hepatitis series, overcoming gaps to lessen the burden and impact. Hepatitis B is in general a progressive disease. Approximately 2 people die every moment from complications associated with hepatitis B, including cirrhosis and liver cancer. Individuals are chronically infected worldwide today. 10% are diagnosed, and less than 1% are currently receiving treatment. Infected individuals go on and progress to cirrhosis or liver cancer, but all patients infected are at risk of stigma of different types, as well as being infectious. We can manage cirrhosis and liver cancer with surgery, local regional therapy, systemic and liver transplant specifically for liver cancer, and of course, liver transplant is an option for patients with liver failure. Hepatitis B disease progression and impact vary by patient. We have chronic infection, we have chronic hepatitis, we have occult hepatitis B, we have inactive disease and a risk of reactivation. And as we mentioned before, liver cancer, which is lifetime risk, and decompensated cirrhosis, depending on a number of different factors. WHO hepatitis elimination targets are highlighted here. We're trying to have a 3-dose vaccine coverage for infants globally over 90% by 2030. And indeed, we want to prevent mother-to-child transmission of hepatitis B with vaccine coverage as well. We want improved blood and injection safety. We want harm reduction with sterile syringes and needle sets, increase per person per year for those who inject drugs. We want an increased diagnosis of hepatitis B alongside hepatitis C. Thus, the incidence of chronic hepatitis B and C infections may have up to a 90% reduction, and mortality target reduction would be 65%. Federal attention has been paid to viral hepatitis, including hepatitis B. We have minimal progress in reducing new hepatitis B infections overall, according to the CDC in 2020. We have the Healthy People 2030 program. There's a number of federal documents that outline strategic plans and progress reports. But we've had new cases increasing since 2012, built in really to the opioid epidemic and changes in harm reduction. What about adult hepatitis B vaccination? Where are we now? This is a very simple number to think about. 70% of adults in the US are unprotected against hepatitis B in 2018. Section 317 immunization program. Funding and hepatitis B are a focus. States and jurisdictions stated that policies don't support efforts for universal hepatitis B vaccination. How much Section 317 funding jurisdictions receive to purchase eligible vaccines are highlighted here. 67% of different jurisdictional health departments receive less than $1 million in Section 317 fund to provide all eligible vaccines. There are strict eligibility criteria. There's heterogeneity state by state. Funds are not distributed evenly, and there's restrictive criteria. This means that key populations will be missed with vaccination programs. This is very important. We now have an ACIP recommendation for November 2021 that all adults aged 19 to 59 should receive hepatitis B vaccine without a risk assessment. Adults older than age 60 with risk factors for hepatitis B infection should get a vaccine. And they worded this carefully. Groups that may receive hepatitis B vaccination are adults 60 years of age or older without known risk factors for hepatitis B infection. We're expecting the CDC to immortalize these statements shortly in the MMWR. Let's now talk about this triple panel. Hepatitis B surface antigen indicates infection if positive. In somebody who's surface antigen positive, check for delta hepatitis. Delta is also a vaccine preventable disease by protecting against hepatitis B. Core antibody total indicates exposure to hepatitis B and persistence of virus in the form of cccDNA. There's no need for vaccine boosting in core antibody positive patients. Although this is mentioned in some guidelines, there's no evidence or peer-reviewed publication to support that this has a clinical benefit. If an individual is surface antibody positive, core negative, surface antigen negative, that indicates vaccine-induced immunity. But if someone is surface antibody positive and core antibody positive, this indicates immune control because core antibody dominates in this clinical assessment. Core antibody has a false positive rate of only 2 per 1,000, even in low-risk individuals. If all 3 tests are negative, consider vaccination for hepatitis B after determining their hepatitis B vaccine history, the time since the last dose of the hepatitis B vaccination, and they may be at risk or in need of boosting. In my professional opinion, to make things very simple, I think that we should be recommending vaccination for hepatitis B for all adults. This, of course, is for all adults who are triple panel negative. And this is an important issue because it reduces not just disease itself, but can decrease stigma and infectivity. It's still important to take a risk history. We talked about individuals older than age 59, that's 60 and above, at risk, should of course be tested, but vaccination is very important. And risk factors have to do with place of birth, endemicity of hepatitis B in those birth countries, US-born children of immigrants from high-risk areas, household and sexual contacts, individuals who have ever injected drugs, high-risk sexual behavior, elevated enzymes, liver enzymes, individuals infected with hepatitis C or HIV, dialysis, and of course, all pregnant women. Now, these are high-risk individuals who need to be tested, but of course, linked to vaccination for hepatitis B. Viral hepatitis elimination is a multi-step process. We really want to see viral hepatitis planning in alignment with ACIP recommendations and expected CDC recommendations. We want to increase hepatitis B vaccination rates among adults. And then we discuss risk history for those age greater than 59. But we need to take a risk history in all of our patients because this is part of general medical care. Very interesting about the Association of State and Territorial Health Officials conducting a series of workshops on policy and solutions to advance hepatitis elimination or health equity. These are to address disparities in adult vaccination and harmonize and bring us to a very high hepatitis B vaccination rate, meaning the 2030 WHO targets. Cost effectiveness has already been established for vaccination between that 19 and 59 age group. How can we support our health departments? Increase state funding to buy hepatitis B vaccines for adults. Expand coverage under Section 317. This would include those at risk older than age 59. Increase staff to assist in vaccine distribution and administration. We need to ensure insurance, Medicaid, and Medicare coverage. We need nationwide mirroring of the California state law, AB 297, to mandate all healthcare providers to offer hepatitis B and C testing. What can more funds do for us? Increase capacity, increase outreach, increase enrollment in various programs that would link to vaccination, increase provider sites for vaccine administration. We can strengthen key partnerships for vaccine administration as well, and continue to support education and awareness efforts. This increases interest in vaccination, and knowledge of vaccine efficacy and safety. We believe that all patients and providers should know their ABDCCs. We know that hepatitis A is vaccine preventable, but we're emphasizing today hepatitis B vaccination as a major action item. The little d here, of course, is testing for Delta in surface antigen positive patients because Delta is a vaccine preventable disease. We vaccinate for B, we prevent Delta. The C here is hepatitis C, which is curable. And the second C, of course, is the coronavirus. COVID testing can allow us to link to better vaccine education for hepatitis B. Let's talk about some key take-home points, some simplified pillars of hepatitis B vaccination. Before you vaccinate or at the same time you're giving your first vaccination, make sure there's a hepatitis B triple panel in that patient's chart. High-risk group testing, we highlighted earlier. Knowledge of high risk is very important. If a patient is core antibody positive alone or with surface antibody, this means exposure to hepatitis B and vaccine has no benefit. In that special case, we educate about hepatitis B reactivation risk. Remember, the core test has a very low false positive rate. The simple message is vaccinate all adults who are triple negative.
Thank you very much, Dr. Gish, and thank you to our listeners for joining us. As a reminder, to view the full program, Adult Hepatitis B Vaccination, Keys to HBV Prevention and Control, and to download the slide set associated with this discussion on the Clinical Care Options website, click on the link in the show notes. As always, thank you for listening.